In this second hour, we have voiding dysfunction. First is Timothy Boone, Therapeutic Effects of Non-invasive Individualized Cortical Modulation using Transcranial Rotating Permanent Magnetic Stimulation to improve voiding dysfunction in female patients with multiple sclerosis. Karl Kreder will talk about intravenous administration of toll-like receptors for Antagonist, TAK242 attenuates bladder pain in an IC bladder pain like mouse model. Dr. Kreder is a new member. I'll be presenting on the effect of age and multiple vaginal births on urinary bladder, sphincter, and function and pelvic support in non-human primates today.
President Flanagan, Secretary Badlani, members and guests, it's my pleasure to present our study on therapeutic effects of non-invasive individualized cortical modulation using transcranial rotating permanent magnet stimulation to improve voiding function in female patients with multiple sclerosis. These are our preliminary results. My collaborators and disclosures are shown on this slide. I'd like to particularly point out Rose Kavari. This is part of her K-23 grant, and she continues to work in this field. I have a single disclosure as an investigator on the ASCO trial with Boston Scientific. Our rationale for trying to intervene in multiple sclerosis is that this voiding dysfunction is characterized in many patients by incomplete bladder emptying and urinary retention. It's very common in neurogenic patients. The only available therapy for voiding dysfunction with moderate effectiveness is catheterization. We decided to shift our focus to the bladder to brain interaction, and our hypothesis was that by modulating cortical regions involved at voiding initiation using TRPMS, we can influence voiding dysfunction in a positive way. Brain imaging has really revolutionized our studies in neurology. It started with PET scans in the late 90s, followed by functional MRI without a tracer in 2005. It's a fairly young technology, but it's truly revolutionizing neurology. And we also see that brainstem regions correlate very well with all the animal studies that have been done over the last century. By convention, we look at activation shown in red or deactivation in blue, which depicts a reduction in the Bowl signal, which is the oxygenation that increases with neuronal activity. So it can be either up or down, and normal Bowl activity in neighboring structures remain gray. We started our studies in the animal lab back in 2013, and I presented to this group a rat study using filling and contraction phases. And you can see distinctly on the left and the right below that with filling, the functional MRI has a very distinct pattern which radically changes on contraction of the bladder. And you can see the rat that we were doing simultaneous urodynamics and functional scanning being moved into the small bore functional scanner. We then translated this to the human condition and began to identify neural correlates of voiding using concurrent functional MRI imaging with urodynamic testing at the same time. We started with 5 healthy premenopausal female subjects who were normal. They were screened at baseline in the clinic showing normal urodynamic testing. And then we went on to publish combined intervention in 25 normal females. This served as our baseline. You can see the intense activation that occurs with voiding below. The voiding contractions are shown with asterisks, and the simultaneous functional MRI is shown in the pictures of the brain. We moved forward and compared multiple sclerosis females in a very similar fashion. And we took images at the time of strong desire to void. We also had the voiding phase, but our interest was primarily in the initiation of voiding. This shows, again, the characteristic voiding contractions at the top The healthy controls are shown in the first line, followed by multiple sclerosis patients on the second line. You can see the marked difference in activation in the multiple sclerosis patient compared to healthy control. We then subtracted the images and the voxels between MS and healthy control patients in the third bar. And we also looked at neurogenic intrusive overactivity, again at the very bottom. And again, you can see marked changes when you subtract healthy controls from the imaging seen in multiple sclerosis females. We published this in the journal in 2016. So our question is, could we change voiding function and improve it using bowl signal changes along with transcranial magnetic stimulation? Transcranial magnetic stimulation has been around for a while. You can see this magnet that stimulates a single area in the cortex, but again, you're limited to a single site and it's quite bulky. We were then fortunate to have colleagues at Methodist who had built and had patented a transcranial magnetic stimulation system with multiple magnets that could stimulate several sites in the brain simultaneously. This was done to try to rehabilitate chronic stroke patients, and it occurred to us that maybe we could use this to change the pattern of voiding in the brain and subsequently the bladder, utilizing it in our MS patient population. This just shows the magnetic cap with the magnets that cause the stimulation of about a 2 centimeter area of the cortex. So we used fiducials, which you can see in the upper left-hand corner in the functional MRI scanner to help us coordinate placement of the magnets. The middle frontal gyrus is shown in the middle, and an inferior frontal gyrus, another stimulation area, is shown in the upper right panel. We use a neoprene skull cap. The fiducials are actually placed on the cap to help us with localizing the magnets in the proper brain areas, and then they're sewn on the cap based on coordinates using the Montreal Institute coordinate system, which is standard for EEG measurements anyway. We have areas of interest based on our primary regions that were studied in MS. We have areas that we wanted to stimulate that were underactive, and those that were overactive, we wanted to inhibit those. And you simply change the frequency of the magnetic stimulation and you get either stimulation or inhibition depending on what you wanted to achieve. This just shows the magnet on a patient and the corresponding areas of the brain we're trying to stimulate or inhibit. This is another image of the motor and the magnet along with the controller. It's actually controlled with an iPad. And so it can be done at home or it can be done easily in an outpatient setting. We can simultaneously both stimulate and inhibit specific cortical regions at the same time. It's portable, it's non-invasive, and like I said, it can run with an iPad. This is just a larger diagram which shows the motor turning, creating electrical field, which can be directed to the cortical areas of the brain. Our regions to modulate are shown here. We had several we wanted to stimulate in the cortical area and try to mimic normal voiding function from these cortical areas. And then we had several we wanted to inhibit to improve voiding and emptying, and those are shown at the bottom. They're largely the frontal gyrus in the left prefrontal cortex to stimulate, and the supplemental motor area of the pelvic floor in the right middle frontal gyrus. So these are the areas we decided to investigate based on our prior studies. The protocol is certainly with clinicaltrials.gov, and we were doing simultaneously neuroimaging data at baseline and after treatment with functional MRI and collecting clinical data at baseline and after treatment. This included non-instrumented Euroflow in a series of validated questionnaires, and our hypothesis was that we could modulate activation of brain regions during the bladder filling and emptying cycle and improve the clinical situation for females with MS. Our inclusion were adult female. We wanted clinically stable MS with bladder symptoms more than 3 months. And our avoiding dysfunction definition was the percent of post-void residual versus over bladder capacity being greater than or equal to 40%, or use the Liverpool nomogram percentile. And again, this just showed poor emptying at the 10th or lower percentile, and patients had to perform self-catheterization. The exclusions are shown on the right, and again, this was female only. This is our device setup and protocol. We placed the cap with the fiducials, very similar to an EEG skull tap. The patient's placed in the functional scanner with urodynamic equipment, which exit through a portal to another room because of the magnetic characteristics of urodynamic equipment. We ran 3 cycles depending on how well they run, and this is filling and emptying times 3. We run the scan simultaneously. We identify our regions of interest on the scan using the fiducials to help orient ourselves. The cap is placed, the magnets are sewn to the cap over the particular areas of interest. And then there are 10 treatment sessions, 40 minutes with each session. And again, this follows the stroke data and use of the equipment in the stroke patients. This is our non-instrumented uroflow after stimulation. This shows baseline and post-treatment in red. You can see that we had a significant reduction in post-void residual. We also had a change, an improvement in the percent of PVR over bladder capacity. And this correlated as well to the Liverpool nomogram of improvement. This is an example of the change in uroflow. The baseline is at the bottom on the left, and the flow after treatment is shown above. And again, the bladder capacity and emptying markedly improved with a post-void residual of only 11 cc's post-treatment in the upper uroflow diagram. We also gave validated questionnaires. This is a representative example of several of those. Do you experience difficulty emptying your bladder? You can see a statistically significant improvement. Have you found yourself that you stopped and started again? Again, improvement was shown on the symptom score. We also had over the last month, how many times do you get up? A nocturia score with improvement as well, followed by the neurogenic bladder symptom score, which is specially specific for neurogenic bladder, improvement in incontinence, and also quality of life. So early preliminarily in these 10 patients, it showed improvement. Our conclusion is that transcranial rotating permanent magnetic stimulation was able to increase activation in the modulated regions, along with stimulation inhibition. These cortical and subcortical regions we know are involved during storage and also the voiding phase. And we think that cortical modulation may have helped increase the strength of connectivity in the voiding network. And that's the next area we're working on. And these changes were actually reflected in clinical improvement, both objective through uroflow and subjectively through validated questionnaires. So the next phase of our study is looking at connectivity and timing between these circuits to see what modulation will do to connectivity. I'd like to thank you very much for your attention and be glad to answer questions.
Our topic today is inhibition of toll-like receptor 4 for the treatment of cystitis pain. This work was conducted as part of the MAP Research Network study. I've structured the talk today to begin with a little description of the role of toll-like receptors in the immune system. I'll then move on and talk about our prior work in human subjects as part of the multidisciplinary approach to pelvic pain, or MAP grant. I'll then describe the development of the Iowa transgenic animal model of interstitial cystitis, and then the results of some work with TLR4 inhibition in that transgenic model. So toll-like receptors are a class of proteins that play a fundamental role in the innate or primitive immune system. They were first described in Drosophila in 1986, and the person who first discovered them exclaimed, "Das ist ja toll," which loosely translated means "this is wonderful," and so the name toll was applied to these receptors. Subsequently, these receptors were shown to be present in vertebrates and invertebrates, and even in plants and bacteria. And in all of those species, they're known as toll-like receptors. So toll-like receptors 1 to 10 have been described in humans. TLR4 is stimulated by gram-negative bacteria. And these receptors are found on our first responder cells of macrophages, monocytes, and dendritic cells. So our hypotheses in this sub-study performed under the multidisciplinary approach of the study of chronic pelvic pain was that greater TLR4 inflammatory response in peripheral blood would be associated with pain outside of the pelvic region, increased pain sensitivity, and more of the comorbid somatic syndromes. So the way you perform this TLR stimulation assay is you take peripheral blood, you centrifuge it, and then you isolate the peripheral blood mononuclear cells, incubate them with LPS for 72 hours, and then measure how much IL-1, IL-6, and TNF-alpha is produced. So what we found is that the TLR4 inflammatory response was associated with both the presence and the number of comorbid conditions. So those with a higher TLR4 response were more likely to have irritable bowel syndrome, vulvodynia, temporomandibular joint disease, chronic fatigue syndrome, and fibromyalgia, in addition to interstitial cystitis. And also those with a higher level of TLR4 reactivity had more of these comorbid syndromes. We also found that those were with a higher inflammatory TLR4 response had more widespread pain, as evidenced by the body map that you see here. And that TLR4 inflammation predicted their pain pressure threshold and the course of their disease over time. So in those with a higher TLR4 inflammatory response, they were much more sensitive to pain. And in those with the highest quartile, pictured in the red line on the right side, they were much less likely to improve in their symptoms over time as compared with those in the lowest quartile, pictured with the black line. So to summarize the findings in humans, TLR4 inflammatory response predicted comorbid disease, that is disease outside the bladder, systemic disease. It predicted increased pain sensitivity, pain outside the pelvis, and symptom change over time. So concurrently, we worked on developing a mouse model, and what we did was we have a oval albumin or oval mouse model, which expresses the ova antigen on the urothelium. And then approximately 7 days after you inject intravenous ova-specific T cells, they demonstrate an inflammatory response that's very similar to what we see in interstitial cystitis patients. So in the mice, they exhibit pelvic pain, voiding dysfunction, and higher mast cell counts, much like IC patients do. They also have increased splenocyte production of TLR4-mediated cytokines, IL-1, IL-6, and TNF-alpha after the cystitis induction. So TAK242, what is this? TAK-242 is a TLR4 selective antagonist. It's been used in studies for sepsis in humans, and it's been shown to be safe in humans and in rodents. So what we did is we had several experimental groups that you see here, a normal mouse, and then our cystitis model mouse that we induced the cystitis in. And on day 7, we treated groups 2 through 6 with either vehicle, which is basically placebo, or escalating doses of TAK-242. And then 1 hour after that treatment, we then examined all groups for their bladder distension evoked bladder pain and the splenocyte production of LPS-induced IL-6. And this is what we found. After IV administration of TAK-242, we found a dose-dependent response reduction in bladder pain, as you see here. And here you can see we had a increased splenocyte production of IL-6 on this side. This is the cystitis vehicle treated, and then these are the escalating dosages. And you can see that the splenocyte production is decreased in response to increasing doses of TAK-242. So we concluded that TAK-242 effectively attenuates local and systemic pain through the inhibition of TLR4 activation in this Euro-ova interstitial cystitis mouse model, and that TAK-242 may be a potentially useful therapeutic agent for the treatment of interstitial cystitis pain in humans. And I just want to recognize this is our interstitial cystitis research team at Iowa, and all of the people pictured here had a role in this work. Thank you.
I'd like to thank the council for allowing me to present our work to you. This work is supported by NIDDK. I'd like to thank Cody Williams, Shannon Langford, Julie Bennington, who've done the bulk of the work in allowing me to present this to you. Female pelvic health has many variables. Anatomy is one, the genetic influences, life events, lifestyle influences, as well as cultural influences. The outcomes also depend on form and function, bother versus no bother, and the definition of successful treatment. Both aging and childbirth are associated with low urinary tract dysfunction. However, the relative contribution of the urinary bladder, the urinary sphincter dysfunction, and pelvic support remain unclear. This study uses non-human primates to address this issue. Why female non-human primates? Because they simulate a female patient in most aspects, except perhaps inability to verbalize their symptoms. Over the last decade, we have carefully studied and characterized this model. First, studying anatomically, looking at proximal to distal urethra, showing the fusion of the distal urethra and the vagina. We've looked at histologically the height of the mucosa, hormonal influences, as well as the muscle versus fibrous tissue in the urethra and the support mechanism in a whole bladder model. We have looked at the nerve distribution in the submucosal as well as in the muscle in order to characterize the nerve distribution, as well as study it functionally with electrical field stimulation from proximal to the distal urethra. And finally, pharmacologically looking at different segments with the help of Karl Anderson, who was here with us several years ago. After this, we were able to create a reproducible model of urinary incontinence in the primate by denervation of the urethra while maintaining bladder function. This has been studied, and we have studied not only the functional aspect, but also looking at it radiologically before, after injury, and after repair with a sling in this particular situation. We then went on to doing the muscle precursor cell injection in an acute injury versus a chronic injury, showing that the acute injury responded well to cell therapy, whereas the chronic model did not. And the muscle and the fibrous tissue content was different in both models, showing much more fibrous tissue in the chronic intervention. The use of chemokine CXCL showed better results in the chronic injury model by harvesting the host-derived stem cells from both the bone marrow and the surrounding tissue, very similar to an injury repair done by the host. In all these experiments, in addition to the difference between the chronic and the acute model, we were able to observe the cell therapy efficacy was reduced 40% in the older versus the younger monkeys. The cell therapy was reduced by 35% in heavier versus thinner monkeys. Based on this, in this non-interventional study, we compared older monkeys, multiparous, versus nulliparous young monkeys. We evaluated their leak point pressures, their urodynamic characteristic, including urethral pressure profile, as well as response to pudendal nerve stimulation for the urinary sphincter. The urinary sphincter, bladder, and pelvic support muscles were examined for collagen content, and a variety of stains were used to characterize this better. So if you look at the H&E and Mason trichome staining, you can see the multiparous bladder in terms of the bladder versus the fibrous tissue, showing a different characteristic and much more muscle content in the nulliparous bladder. Whereas the sphincter itself, again, multiparous showed disorganization of the muscle, and nulliparous sphincter showed more organized structure. With CT fire staining, you're able to characterize the muscle, the collagen fibers much more in detail. And we were able to study this comparing to the nulliparous. We measured the collagen fiber width, the fiber length, comparing nulliparous to multiparous, showing the straightness of the fibers, and then the angle of the fibers as they are laid in the tissue. So in this money slide, basically showing you the sphincter collagen content quantifiably was not different. Resting urethral pressure profile was not different. The main difference is in the leak point pressure related to abdominal leak point pressure, where it was significantly lower in the multiparous monkeys. The other big difference was the collagen content of the pelvic floor. The unexpected results were the urethral pressure profile secondary to electrical stimulation was more in the multiparous, which is unexplained. So in conclusion, abdominal leak point pressure was significantly lower in the older multiparous group. The bladder collagen fiber in the older multiparous monkeys had larger diameter, were shorter, more asymmetric compared to the younger. The levator ani and the coccygeus muscle had greater amount of collagen versus the muscle fibers in the multiparous older monkeys. The aging and the multiple births appeared to be associated with bladder dysfunction and reduced pelvic muscle support rather than dysfunction of the urinary sphincter itself. The structural explanation of the bladder may be related to the effects of aging, and inability of the pelvic support muscle contract may explain the reduced Valsalva leak point pressure. Thank you very much for your attention.